We are live. We are live. Dr. Apurva, we are live.
Can you see my screen?
Yes.
Yes, okay. I didn't know I was muted. Apologies. Welcome to AIOS GuruSangam 24-25 edition, the episode 14. This is a Retina episode. Our chairman is our president AIOS, Dr. Samakumar Basak. I'm your moderator for today's evening. My name is Dr. Apurva Ayachit. I'm a VR surgeon at MM Joshi Eye Institute, Hubli. Our program directors and the brain behind this whole Guru Sangam is, of course, Dr. Santosh Honavar. We've had some amazing episodes so far, spanning all the specialties in ophthalmology. Our another program director is Dr. Manoj Mathur, who is the treasurer AIOS. Our expert panel is composed of a galaxy of vitreoretinal experts from across the country. It is my great pleasure to introduce each one of them. Dr. Deependra Vikram Singh is the head and director of IQ Super Specialty Hospitals. He is the chief vitreoretinal surgeon at Gurugram. He has more than 65 publications and more than 15 book chapters. Welcome, sir. Next is Dr. Dinesh Garg. We all know him as he's a regular fixture in most state and national conferences. He has 3 decades of experience in vitreoretina and has his own center, Advanced Center of Eyes, at Ludhiana. He also has more than 130 national and international presentations. Dr. Manoj Khatri, we all know as an ophthalmic leader. He has held leadership positions at both AIOS and VRSI. He's a consultant vitreoretinal surgeon with many years of experience at Agarwal Eye Hospital, Chennai. Dr. Mukesh Porwal heads his advanced retina hospital called the Retina Hospital at Rajkot, and he has been president of the Rajkot Ophthalmological Society, and he has also a very large experience in the field of vitreoretina. We all know Dr. Paritosh Kamdar. He has more than 35 years experience in vitreoretina, and he practices at Jesham Eye Institute, Mumbai. We all know him from his regular feature in various conferences. Dr. Rupak Kanti Biswas is the head of retina at Netralayam, Kolkata, and is a pioneering VR surgeon in that part of the country. He has many innumerable publications and presentations at regional, state, and national conferences. So, with this star-studded expert panel, we move on to the speakers. So our first topic today is understanding retinal vein occlusions, pathophysiology, diagnosis, and treatment. All the 3 topics today are going to be extremely helpful, especially for residents and fellows. So I urge all the residents and fellows to pay close attention to all the topics and what the speakers have got to say. And with the pearls from the expert panel, I'm sure a lot of mysteries in these basic topics will be decoded. So, Dr. Ankur Singh is Associate Professor, Department of Ophthalmology at UCMS, Delhi. He is a vitreoretinal and uveitis specialist and has 10 years of faculty experience and does a lot of advanced retinal surgeries. He has been a convener and trainer for state and national level skill transfer courses, has got various awards. Some of them, notable ones are the Best Video Award at APVRS Congress 2019. He has multiple peer-reviewed publications, and his other responsibilities include being the secretary of the Teachers Association at the college, that is UCMS, and executive member, Delhi Ophthalmological Society. So without further ado, I will request Dr. Ankur Singh to start sharing his slides and start his talk.
I hope the slides are visible.
Yes.
Yes.
Thank you, Dr. Purva, for such a beautiful introduction. And at the very onset, I would like to thank Dr. Basak, Dr. Mathur, Dr. Honavar sir for this opportunity. So I'm going to talk about retinal venous occlusion, the pathophysiology, diagnosis, and the treatment. So Retinal venous occlusion is the second most common retinal vascular disorder following diabetic retinopathy. It is often associated with vision loss. Partial or complete obstruction of the retinal vein is seen in RVO, and it is classified based on the location of the occlusion. So if the occlusion is happening at the laminar area of the optic nerve, where the lamina cribrosa is there, or in the retrolaminar area, the patient is going to develop a pathology which is called as central retinal venous occlusion. If it is going to happen, if the thrombus formation of the occlusion is going to happen in the persistent vestigial bifurcation in the retrolaminar portion of the central retinal vein, it is going to affect either the superior or the inferior half of the retina and is known as hemicentral retinal venous occlusion. If the thrombus is forming at the atriovenous junction in the retina, it is going to affect one quadrant of the retina and is going to be called as branch retinal venous occlusion. So, like any disease, this disease also has a risk factors, and it commonly occurs in the between fifth and the seventh decade of the life. It is relatively uncommon in individuals less than 40 years of age. The common risk factors, as described by eye disease case control studies, are systemic arterial hypertension, open angle glaucoma, diabetes mellitus for CRVO, and for BRVO, it is these factors as well as hyperlipidemia, cardiovascular disease, hypercoagulability, hypothyroidism, and cigarette smoking. Like CRVO, diabetes mellitus is not as such a risk factor. The risk factor is high body mass index. So let's discuss each entity in detail. So let's discuss central retinal venous occlusion, which is CRVO. So CRVO is less common than VRPO, occurs predominantly in person aged more than 65 years of age. If it occurs in a young individual, you have to look at the coagulability profile of that patient or any inflammatory etiology that could have led to CRVO at this young age. There is significant decrease in vision. It is usually a unilateral disease. However, 7% of patients with CRVO in one eye can develop CRVO on the other eye in a follow-up of 5 years. So how does it happen? There is atherosclerosis and there is the tension at the lamina cribrosa. So atherosclerosis with the fibrous tissue of the lamina cribrosa compresses the veins, and it leads to the turbulence, which leads to the thrombus formation. And this thrombus formation increases the intravascular the pressure, which leads to massive intraretinal edema in ischemic kind of CRVO and macular edema, as well as can also lead to macular ischemia. When there's a lot of macular capillary non-perfusion area on the retina, it leads to increased VEGF that can lead to neovascularization of the angle and the iris, and then this can cause neovascular glaucoma. Then there is an entity called as non-ischemic kind of CRVO, and the ischemic and non-ischemic kind of CRVO was defined based on the CVO study, and these findings were based on FFA. So if the amount of CNP area on the FFA was more than 10 disc diameter, probably this was a patient of an ischemic kind of CRVO. If it is less than 10 disc diameter, then it is a patient of non-ischemic kind of CRVO. A non-ischemic kind of CRVO patient had to have an occlusion or thrombus formation in the posterior or the lateral region, more posterior to the lamina cribrosa, and there are collaterals there. That is why these patients have to have less hemorrhage compared to the ischemic. So if you look at this picture, you will see this one with the orange box is the lamina cribrosa. So any occlusion happening at this level or adjacent to it is going to produce a massive intraretinal hemorrhage in the form of flame-shaped hemorrhages, as can be seen in the image below in the orange. And because there's so much insult of the retina that has happened, these patients tend to have an RAPD. On the other hand side, if the occlusion, because they are collateral, if you can see in this purple box, tend to have some sparing effect. So if any occlusion happening in this violet box, around the area in the violet box, then you tend to have a non-ischemic kind of CRVO, which has lesser hemorrhages, and most of the patients do not have these RAPD, the sign of RAPD. So you cannot go and do an FFA at the very beginning, the patient, at the very moment the patient comes in. So you have to look at the telltale signs. So telltale signs that can help you to differentiate between ischemic and a non-ischemic kind of CRVO, one of which is visual acuity. If the patient has a visual acuity of around 20 by 200 or worse, probably you're looking at a greater ischemia, and probably this patient is a ischemic kind of CRVO. If the patient has an afferent pupillary or relative afferent pupillary defect, again, ischemic kind of CRVO. If there's a negative waveform on electroretinogram, again, this is ischemic kind of CRVO. So why it is important to know, is it ischemic or a non-ischemic? Because 35% patients of ischemic kind of CRVO will develop, this is 1/3, will develop NVI or NVA. And this will lead to 45% risk of developing neovascular glaucoma by 3 years. And we all know how dreaded neovascular glaucoma as a disease is. And if it is a perfused or a non-ischemic kind of CRVO, the patient will have a better visual acuity, will have a lesser risk of neovascular complication. But however, you need to remember that 1/3 of these patients, which are non-ischemic kind of CRVO patients, tend to convert into ischemic kind of CRVO. So how do these patients present to us? They usually present to us with sudden painless visual loss, usually in the early morning hours, because there is nocturnal atrial hypotension. The same thrombus, which was still same compression, which was allowing the blood to pass through, because of the hypotension, nocturnal hypotension will not allow. This will lead to turbulence. Again, this will lead to thrombus formation, and the cascade will go on, leading to occlusion. So that is why these patients tend to wake up with visual loss. At the same time, some patient can come to you with a blood vision that worsens over the day. Patients, if the thrombus, because of the arterial pressure, moves out or moves away, then the patient can come to you with a history of transient obscuration of the vision. Patient might have metamorphopsia because of the associated macular edema in these patients. And then there are few patients, quite less in number, that tend to develop vitreous hemorrhage, can have a scotoma, or because of the dense intraretinal flame-shaped hemorrhages, that is another cause of the scotoma. So how do these patients look like? So these are the patients which are going to have massive intraretinal hemorrhages, which are spread in all four quadrants. They would be dilated tortuous veins. Apart from those veins, dilated tortuous veins, those hemorrhages, you're going to have a cotton wool spot, and this will make you make this patient look like the term described, the blood and thunder appearance. So what are the causes these patients have low vision? One of the most important causes is macular edema, and at the same time, the second cause is because the hemorrhage itself. Then, as we have just talked about, that these patients have high chances of developing neovascular glaucoma. So these patients have high chances of developing neovascular angle and neovascular iris. So you need to do a good slit lamp examination. You need to do gonioscopy, because if you don't do gonioscopy, you are going to miss those 12% of eyes which do not have NVI but still have NVA. NVI can be seen by slit lamp examination, and some certain times these patients comes to you would have subtle, small, less hemorrhages, gauze vessels. Probably this is an old patient of a CRVO, in which the hemorrhages have resolved. The gauze vessels are the predictor. The retinal thinning are the predictor of the insult that has happened. And there might be a few patients who have decreased vision, knocked out macula because of the macular ischemia, and all that patient has is collateral. So this is a patient who has developed collaterals now. So if you see a collateral with a patient having those massive CNP areas, then probably this was an old patient of CRVO. So as we have discussed before, every patient who comes to you with this clinical picture needs to be evaluated well for visual acuity, for pupillary reaction, for intraocular pressure, slit examination, gonioscopy, and ophthalmic fundus examination, as we have discussed. Apart from that, the patient has to undergo OCT. OCT help us to quantify the macular edema, evaluate the response to the treatment. At the same time, fundus fluorescein angiography will help you after a certain time, will help you to assess the amount of retinal ischemia, the perfusion status of the macula, as well as going to help you to diagnose macular edema apart from the OCT. So most of the patient who was in the range of CRVO, usually does not require an investigation. So if you have known risk factors, you know the patient is diabetic or hypertensive, you don't need to investigate the patient further if it is in the right age group. So if the patient is young, bilateral disease, then you have to think, as I have discussed before, for the disorders like blood dyscariasis, and you need to investigate, give them the panel of tests required to assess any blood dyscariasis or any hypercoagulable conditions. So just like any disease, this disease also has a differential diagnosis. Certain diseases can have a fundus picture like of CRVO, and you are confused what you are looking at. So one such disease entity is an ocular ischemic syndrome. So ocular ischemic syndrome, the occlusion is a chronic phenomena. So you will not see any tortuous vessels. You will not see any disc edema. And the hemorrhages that are going to happen in these patients are deeper. So these will be dot and blot hemorrhages. At the same time, these hemorrhages are going to the periphery, more in the periphery rather than in the center. At the same time, the patient of diabetic retinopathy can also, give you a confusion that this is a CRV or a diabetic retinopathy. But it's very simple. Diabetic retinopathy will have those well-described diabetic retinopathy changes like beading and looping. Will have macular edema, which is going to have some, you're going to have those hard exudates around it. At the same time, those hemorrhages are not going to go to the periphery because diabetic retinopathy is a mid-peripheral disease. At the same time, diabetic papillopathy can have a disc edema, but again, the picture is going to be different and none of the hemorrhage is going to go into the periphery. If the patient has a multiple cotton wool spot, you see these whitish lesions, and he is immunocompromised. Probably you're looking at a human immunodeficiency virus retinopathy. Hypertensive retinopathy grade 4 is especially important because it's going to give you those flame-shaped hemorrhages. It's going to be disc edema, and you can have few tortuous vessels. So how do you differentiate it from CRVO? These hemorrhages are not going to go to the periphery. So what goes to the periphery is not hypertensive retinopathy, rather a patient of a CRVO. And then there are choroidopathy changes that can be seen, which is not going to be there in CRVO. So there is no treatment that can reverse CRVO. All that we can do is treat the complication associated with CRVO. That is, we are treating iris neovascularization, we are treating macular edema, and it is best managed by anti-VEGFs. And if the anti-VEGFs are not effective enough, then we can think of second-line drugs, which are steroids. So there's a lot of ischemia is happening in the retina because of this occlusion, and this leads to release of so much of VEGF, an inflammatory mediator, and this leads to macular edema, iris and angle neovascularization, and some in certain cases can lead to vitreous hemorrhage. So this is what you are trying to treat. You are trying to treat the complications. So as I've discussed, the first line complications are anti-VEGF drugs, which includes previously bevacizumab, ranibizumab, aflibercept, and faricimab. Second line are the intravitreal corticosteroids, triamcinolone or dexamethasone implant. So you see these images below. This is how a patient responds to one anti-VEGF injection, a patient of CRVO. So there have been few trials, because this is a postgraduate programs that we need to talk about trials also. The important trials which I'm going to touch upon. One is the ranibizumab 0.5% versus sham trial, which is known as cruise trial. When this another trial that was known as Copernicus or Galileo trial, where aflibercept was used in a patient of macular edema of CRVO. Then Comino trial for faricimab, the dose that was used was 6 milligram. So what these trials told us? These trials told us that when you use these drugs, these drugs leads to significant visual gain and decrease in retinal edema. So as we all know, there is another drug which is available in the market and which does magic, is brolucizumab. So why don't we use brolucizumab in cases of RVO? Because Raven study told us that this drug, when put for a non-inferiority trial against aflibercept, the results were inconclusive. Secondly, there are safety concerns. In few patients, brolucizumab, rather treating RVO, has shown in other subgroup of patients to develop retinal vasculitis and retinal vascular occlusion. So as of now, brolucizumab is still not being used for patient of RVO. Apart from that, the drugs which I have talked before are commonly used drugs for RVO. Bevacizumab was used before off-labelly for treating macular edema in CRVO. So then there are second line drugs, which are steroids. So there was a SCORE trial in which triamcinolone 1 milligram and 4 milligram were used to treat macular edema of CRVO, and they found that 1 milligram was effective and safer than 4 milligram dose, and 4 milligram dose was leading to more increase in cataract and increase in IOP. Then there is this Geneva trial, which was done for Ozurdex, and Ozurdex is dexamethasone implant. And when this was used, this led to rapid improvement in the best corrective visual acuity of these patients. So what is the benefit of these drugs? One, they can be used as reserve drugs. Second is they have a longer duration of action, especially when we are talking of Ozurdex. So then there was this SCO2 study. SCO2 study told us two things. One, that bevacizumab is non-inferior to aflibercept in terms of visual acuity and OCT thickness reduction, improvement in visual acuity at the end of 6 months. And this study also made us understand that we can switch. If a patient is not responding to bevacizumab, we can switch to aflibercept. And if the patient is not responding to aflibercept, the macular edema is not responding to aflibercept, we can switch to steroids. So this was the trial. Although in this trial, the number of patients that required to be switched from aflibercept to dexamethasone was very less. So then CVS, as it told us what is ischemic CRVO and non-ischemic CRVO, it also told us that a patient who does not have an NVA and an NVI, you need not to do PRP. So there's no use of doing a PRP in a patient who hasn't yet developed NVA or NVI. At the same time, once you do a PRP in these patients, the NVI, NVA regresses in 90% of cases within 1 to 2 months of the treatment. And if there are any persistence of these new vessels, new vascular of iris or NVA, close monitoring is required, and additional PRP, if required, needs to be done with or without anti-VEGF. So this is one slide. This is how we used to follow up these CRVO patients before. And I'm not going to discuss this slide in detail. You can take a picture of this when we are done with this class. Then the second is now what we work upon on the follow-up of these patients is with the anti-VEGFs. And for anti-VEGF macular edema, depending on the type of anti-VEGF we are using, we need to follow these patients monthly or bi-monthly. Because there are high chances of macular edema recurrences, close monitoring and frequent treatment for several years are required in this patient. And once the patient is not developing any macular edema, bi-monthly for 6 months, and then annually if the patient is doing pretty well. So then the second entity, which is I'm going to talk about, is branch retinal venous occlusion, or BRVO. As I previously said, that the CRVO is less common. So BRV is more common entity than CRVO. It has a prevalence of 4.2 patients per 1,000 adults. It is strongly associated with systemic vascular diseases, that is hypertension and atherosclerosis. The common age group again for this is 60 to 70 years, and it affects men and women equally. So as I have described before, the pathology is going to happen at the atriovenous junction because the artery and the vein share the common adventitious sheath. So when the atherosclerosis happen and there's increase in the system, there's increase in the the turgor pressure of the artery, this compresses over the vein, which goes even beyond 33%. That leads to the turbulence, leading to thrombus formation. Again, it leads to the venous obstruction, intraretinal hemorrhages, macular edema, and ischemia. So what is the cause? So how does the patient present to us? The patient present to us with sudden painless visual loss. And he can also present to us a visual field defect because those hemorrhages are going to produce, or the CMP area is going to produce a visual field defect. There can be subclinical cases, which patient may be having 6/6 vision, where the fovea or the macula is spared. Some patients tend to come to you when they have those NVE, which has bled, and now they have vitreous hemorrhage, and they come to you with those floaters because of the vitreous hemorrhages. So how do you see what is the picture that is there on the fundus? So these patients tends to have a wedge-shaped intraretinal hemorrhages in the affected retinal quadrant, which is one of the quadrant of the retina. The most common site is the superior temporal quadrant. You will see dilated tortuous vessel because of the sudden occlusion. You will see cotton wool spots. And if this pathology is chronic, you might have telangiectatic vessels. So the image that we have seen previously is the major BRVO. So there's a minor form of BRVO, which is known as macular BRVO, which affects the macular area. So as it is a macular BRVO, so it is going to have more visual disturbances. And because it is limited to the macular side, so it will have a normal peripheral vision. So Just like CVOS described ischemic and non-ischemic CRVO, BVOS described ischemic and non-ischemic BRVO based on the amount of papillary non-perfusion area, that is 5 disc diameter for BRVO. So with the patient, any patient who has more than 5 disc diameter of CNP area and a patient of BRVO, you are looking at a ischemic kind of BRVO. And why is it important to know? Once again, because they have 31 to 41% chances of developing retinal neovascularization elsewhere, or NVE. And when these NVE bleed, either initially they will lead to vitreous hemorrhage, and if they are persistent, chronic, they can lead to even TRDs. Sometimes, because this disease has a good prognosis, it tends to go away by itself even without treatment in few percentage of patients. So sometimes you might see these collateral vessels as seen in this inferior temporal quadrant and those ghost vessels. This is a patient who had BRVO, did not receive any treatment, developed this collateral and is doing pretty well. But however, we need to know that these kind of patients who are not treated, the 40 or 50% of the eyes will have visual acuity not 6 by 6, rather less than that, that is 20 by 40. So if the patient has a persistent poor visual acuity because the patient has chronic macular edema, you have to look for the factors which are leading to the persistence of this macular edema. One, there could be a macular ischemia. Second, there could be a persistence of an ERM over the macula, which is the leading cause of decrease of vision. So apart from just the macular edema, macular ischemia, and the vitreous hemorrhage, what you need to look at is any other pathology which is affecting the fovea, that is ERM or the VMT. So again, the investigation are roughly the same. However, in this patient, if the patient is young, again in this cohort of BRVO, which is less than 50 years of age, bilateral BRVO, you tend to evaluate the patient for hypercoagulable state, homocysteine levels. And if there are numerous BRVOs in this eye, you might need to look for another entity known as inflammatory BRVO. So you look at this picture, this is a patient who has, the perivascular sheathing and intraretinal hemorrhages. This is a case of inflammatory BRVO secondary to an, inflammatory cause. In this case, it is TB. And these patients do not have these occlusions at the atriovenous changes, but rather they have the occlusions at the site where there is this perivascular sheathing happening, or the infiltrates around the vessels are there. So in Indian context, the most common cause of the inflammatory BRVO is tuberculosis. Again, what do we treat in BRVO? We treat the complications. And again, the complications are because of the VEGF. So you are treating the macular edema, you are treating the neovascularization elsewhere, few cases of NVD as well, as which are the patients of ischemic BRVO and vitreous hemorrhage. So again, as in CRVO, we need to optimize the basic parameters. The patient is hypertensive, you need to send the patient to physician to get his to be started on ocular and antihypertensive agents. And just like CVS told us about when to laser, BVS also told us that laser is to be done in a patient of BRVO when the patient develops NVE. And if we do a scatter laser in a patient who has not developed NVE on those CNP areas, it does not provide you with any benefit. Historically, we used to do grid laser for the treatment of macular edema, which now we don't do because we have anti-VEGFs, and various trials have showed the superiority of anti-VEGFs over the grid lasers, one of which for ranibizumab is a Bravo study, for aflibercept is the Vibrant study, and for bevacizumab is Barvolt study. So now we have a bispecific antibody, which is faricimab, which has a longer duration of action, and it was found to be non-inferior to aflibercept while treating the patient of macular edema associated with BRVO. Patient with persistent vitreous hemorrhage secondary to BRVO requires vitrectomy, and once the vitrectomy is done, you do the laser in the CNP areas, the patient is taken care of well. Apart from the anti-VEGF, you have the second line of treatment, that is Ozurdex or the dexamethasone implant. And SCORE BRVO study told us that when we use triamcinolone, it is not superior in visual gain as compared to grid. So you use dexamethasone or anti-VEGF in patients of BRVO, it will do well. Then how do we follow up these patients of BRVO? So to follow up the patient of BRVO, we need to roughly divide these patients into three groups. One patient which has presented to us to you today. So you do a OCT. If the patient has macular edema, you give him 3 injections of anti-VEGF agents, follow him up on monthly because you're giving anti-VEGF. If the patient is having now stable, does not have any macular edema, you can increase the follow-up to 3 months to even 6 months. And do an OCT again whenever the patient comes back to you, look at the macular edema. If it reoccurs, go back, start treating the patient, 1 monthly follow-up. Now there is third entity of the patient who has come to you late. Now you do an FFA, you find this patient having ischemic kind of BRVO, which is again more than 5 disc diameter of the ischemic areas with no active ME or NV. These are the patients which you need to closely follow up. And what we think in CRVO is the only entity which we can develop a neovascular glaucoma. BRVO, ischemic kind, can also develop neovascular glaucoma. So these are the patients you should do ergonioscopy 3 monthly when you are following up these patients. So if the neovascular glaucoma develops, you do a glaucoma surgery. So this is a case example of a BRVO in which we treated the patient with monthly injection of anti-VEGF. What you see on the right, the first slide is a patient, is the fundus picture as well as the corresponding OCT. This patient presented to us with a visual acuity of 6/60 with a cystoid CME associated with BRVO. We gave him monthly injection, and after 4 months, the last picture, what we see is there was resolution of those cotton wool spots. The whitest thing that you see over the fundus is resolved. The vessel tortuosity is slightly better. The hemorrhages are gone. The contour of the fovea has been restored. Although they are inner retinal changes which are suggestive of ischemic insult, but the patient has 6/6 visual acuity. So that covers up for me the topic of CRVO as well as BRVO for RVO. I would be glad if there are any questions for me. Thank you.
Thank you so much, Dr. Ankur. That was indeed an extensive and very well covered topic, a very vast topic covered very well and succinctly in 30 minutes. So I would be asking 3 questions, and I would love it if 2 panelists can take up each question so that we can involve everyone. My first question is to Dr. Dipendra Singh, and then after him, Dr. Dinesh. So we see a lot of younger hypertensives these days. We don't know if they are primary or secondary. So the age group of 35 to 45, because of our sedentary lifestyle, because of poor metabolism, I think primary hypertension is affecting younger and younger patients. So in which group of young patients and what presentation of retinal vein occlusion would you consider working up these younger patients for causes of secondary hypertension, like a renal workup, renal artery Doppler, or a pheochromocytoma workup? In which patients do you consider younger patients? What presentation of RVO? And the second part of the question is, when do you consider workup for hypercoagulable states? So my first question to Dr. Dipendra, after him, Dr. Dinesh can also chip
I
in.
think good question. The younger patients normally they land up with macular BRVOs. Is much more common than a major BRVO. And I think whether it is secondary or primary, most of the times we leave this workup to our physician colleagues or cardiologist colleagues. And obviously, any patient who is having BRVO at a very young age and no documented rise in blood pressure, he's not a known hypertensive, then I think those are the patients, they are a primary suspect for conditions like pheochromocytoma, where they can have episodic hypertension. But in general, unless we see an inflammatory retinal vein occlusion, we almost always ask them to undergo a cardiology checkup, even if he's, let's say, 30 years. We don't skip that part. And then we leave it to cardiologist, then whether he wants to go for renal Doppler or to rule out pheochromocytoma.
Okay. Dinesh, sir?
Yeah, I think very well put. Dr. Dipinder has already told. But I also get a carotid Doppler done. So sometimes these patients may have some, the whole cardiac workup. Sometimes they might have some rheumatic heart disease or a congenital lesion. So, and dyslipidemia again, also I think in North, dyslipidemia and obesity and sedentary lifestyle, they're contributing more to this. And these BRVOs as well as CRVOs, we have seen even during COVID times. And I feel there is a relatively increased incidence after the COVID pandemic.
Yes. Paritosh sir wants to say something.
Yeah, just as a very generic rule, okay, means one is, of course, you look at the whole patient and so on and so forth, what we are classically taught. But in general, if there are soft exudates present, and if the hemorrhages are more dense, which means they're deeper as well as superficial, those are the people whom you would, generally speaking, need to work up more. And younger the patient, you need to work up. The systemic workup would be more intensive. I mean, this is a very generic.
We'll start with you only, sir. Paritosh sir, my next question.
Yeah.
In this day and age, do you feel there is any need to divide RVOs into ischemic and non-ischemic? If you have any baseline clinical or imaging OCT biomarkers to tell you which patient would have a poorer prognosis, please share them.
Yeah, very nice question. So clinically, if you find more arteriosclerosis, second, as I said, ischemia, or on OCT, if you find more hyperreflectivity from the inner or middle layers, those are the eyes where the ischemia is more severe and are likely to, and the closer they are to the center or involving the central macula, the macular ischemia is greater. So that is basically one thing. Sorry, what was your second part of the question? You said
exactly, you've answered it already. Any clinical or imaging biomarkers that will tell you this patient will probably not do so well.
And one more thing which I have found across all vascular retinopathies and even the CNVs of ARMD is smoking.
Yes.
So smokers tend to do poorer than non-smokers.
Yes.
And so far as chronic recalcitrant edemas in all the vascular retinopathies, stress is a very important factor.
Yes.
One more interesting thing which we found in retinal vein occlusions, the ones which are the intermediate types or which are the non-ischemic types, the thrombosis tends to recur when patients inadvertently or deliberately stop their statins. This is something interesting which we have found in our patients and documented.
Okay.
So that's something because pre-operatively, for example, everyone says, okay, stop the blood thinners. Now, blood thinners, for convenience, physicians often prescribe them as a combination of antiplatelet and statin.
Right.
So the patient ends up stopping that. And then everything is forgotten post-surgery about restarting these medications, and stopping the statins we have found to be a major culprit.
Wow,
Patients need to be warned about this.
Okay. That's very interesting.
Yeah. Sometimes actually there are combined artery and vein occlusions. Like
Yes.
in those situations also we need to work up extensively. Like
Yes.
sometimes there is a small artery, like kind of a cilioretinal artery or a macular branch occlusion along with the CRVO or a BL.
Yes.
I had one more important comment that the role of nocturnal hypotension and sleep apnea is very important in all age groups, because the younger ones also nowadays tend to have the metabolic syndrome X, and hence more risk of sleep apnea, dyslipidemia, etc. And in the elderly group, one needs to be very careful about this, and sometimes need to do even a 24-hour ambulatory BP, more to prove to the physician to change the type of antihypertensive and or the timings. So generally, and many of these patients are often on prostate medications for an enlarged prostate. So a combination of a potent antihypertensive with a prostate medication taken at bedtime is lethal. You know, it tends to cause severe nocturnal hypotension. So one needs to be aware about this.
Absolutely, sir. Very
I
well.
think, Dr. Apurva, can I add one more point? So just
Please.
to complete the list, I think more than one occlusion also is a very high risk factor for coexisting systemic comorbidities. Like if it's like bilateral or more than one occlusion in same eye. But to answer your basic question, I think another reason for classifying them ischemic and non-ischemic is if you see predominantly non-ischemic extensive RVOs, then we also look into immune, especially in younger patients. We start looking for immune-related diseases. And patients who present with severe ischemia at the presentation, they are much more likely to have carotid and other occlusions. So it makes a lot of sense in classifying them ischemic versus non-ischemic, and if possible, doing an angiogram whenever hemorrhages, they get absorbed.
Right.
So the
Can I say
to intervene medically and reverse the situation to a great extent. So it's important to classify, that's why.
Yes.
Earlier we catch them, and earlier we do the systemic treatment and modifications, the better are our chances.
Yes.
And
Dr. Mukesh Porwal was wanting to speak.
yes, for BRVOs especially, you find a large number of patients who have undetected hypertension. So as a rule, any patient presenting with BRVO should have the BPs checked in our clinic.
Yes.
No need to wait to send them to a physician and get it confirmed or not confirmed, because it can fluctuate also. So many BRVO patients, especially middle-aged ladies, would have the hypertension diagnosed for the first time when they present with BRVO, not so much with CRV.
Yes.
Right. Yes, sir. Very well put. My last question about RVO. Hope we have. Yes, sir.
Yeah, Dr. Apurva, I think I completely agree with Dr. Kamdar how he has put it off. There are 2-3 points I just wanted to add on to it. Serum homocysteine level is also an important factor and parameter, especially in Indian eyes, in Indians, because this is a parameter which is even in hypertensive or normotensive patients also, they tend to have a little, high level, and if you treat them, the risk definitely reduces significantly. There is another point of triglyceride level and LDL level. Even the LDL level, if it is up to 90, we take it as a normal level, but below 40, if we put it off, the risk of any kind of cardiovascular risk goes down to 3-fold less chance of development. So what Dr. Kamdar was telling, stoppage of statin inadvertently, that actually leads to sudden rise of this LDL level, which goes there. So these are 2 points. Third point is that for our PGs and fellows there, for them, once you see that significant number of corneal spots are there and compared to the hemorrhage, so if you have a significant number of corneal spots, then the chance of hypertensive retinopathy associated or a persistent rise of hypertension or a sudden rise of hypertension, these are the parameter. So you need to look more for the hypertension parameter rather than the lipid level and the other things. So these are the few practical tips and part.
Great, sir.
And also the bilateral presentation is a very important thing. That will tell us that there is a systemic factor involved. Most of the CRVOs can be idiopathic if they are unilateral, but if it is bilateral, then you have to investigate extensively.
Okay. Great. So I'll have one.
Kamdar, do we start statins and antiplatelets ourselves, or we leave that decision?
It is better to be into the cardiological domain. It is better to be, because we are not the person who are updated that much. But again, yes, I will prefer to be under the care of a cardiologist, definitely.
Of course, that is true.
Great. Thank you so much, panel. I think we have all learned a lot from this very illustrating discussion. We'll go on to the next talk. And thank you, Dr. Ankur, again for a wonderful presentation. We've all been very illuminated by the talk as well as the discussion. Our next speaker is Dr. Dipanshu Agarwal. He's a good friend of mine. He's going to speak on clinical signs of diabetic retinopathy and diabetic macular edema. We are not going to be talking about treatment much. It's only a clinical science presentation. He's a consultant Vitreoretina UV and ROP services at Chaitram Netralaya, Indore. And he has performed a very large number of VR surgeries and procedures. His competencies include retinal detachment, DR and its complications, macular surgeries, and complex ocular trauma. And he has over 20 PubMed index publications and has been an avid speaker at regional, state, and national conferences. And he's performed live surgery recently. He's got an IGO Silver Award, IGO Appreciation Award, and has been a winner of the Retina Case Conclave of the YOSI. So I welcome Dr. Dipanshu and I ask him to share his screen and start his presentation. We will have 30 minutes of presentation and 8 to 9 minutes of discussion.
Thank you, ma'am, for the kind introduction. At the outset, I would like to thank Dr. Hunavar sir, Dr. Mathur sir, and President Pasak sir for giving me this opportunity. So for my today's talk in this session is on the topic allotted is clinical assessment and signs of diabetic retinopathy and diabetic macular edema. I will not be touching upon the treatment part. This is the basic gist of how these signs, how do they look and how do they appear. This is all about that. As the panel has elaborately discussed in the previous talk about the history, that is probably one of the most important factors while we treat these vascular lesions. So we need to have a good initial workup. Following that, I will be covering the pathophysiology of diabetic retinopathy and diabetic macular edema, and I'll be showing few clinical signs and pearls regarding the same. So initial workup, apart from your routine examination, includes a very detailed history taking that includes duration of diabetes, which is probably one of the strongest risk factors. Apart from that, one needs to be aware about the medications which the patient is on, whether the patient is on insulin or oral hypoglycemic agents or antihypertensives. And if there has been a recent change in medication, why is that important? Is because there are certain drugs that causes macular edema, like glitazones, which is one of the anti-diabetic medications, tamoxifen, taxanes, and other drugs which can lead to increase in macular edema. So we need to have a list of drugs the patient is on. And apart from that, one should also be aware about the systemic comorbidities which are present in the patient or which might be there in the patient, that which include renal disorders, cardiovascular any previous cardiovascular events, systemic hypertension, hyperlipidemia, or pregnancy in the current state. So once we have taken a detailed history, it is very important to have a detailed anterior segment evaluation, which would include having visual acuity and IOP documented at every visit. Following that, one should evaluate clinically. The corneal sensations need to be checked thoroughly because these are sometimes reduced in diabetic patients. Apart from that, iris and angles need to be evaluated because there could be presence of NVIs or NVAs on gonio. And apart from that, pupillary reaction and lens status is important in order to assess the cataractous changes that might be presenting early in the patient with diabetes. So when we talk about fundus evaluation or fundus findings, there are various signs which will probably help you in diagnosing the state of diabetic retinopathy or the grade of diabetic retinopathy, be it intraretinal hemorrhages, be it hard exudates, be it cotton wool spots or flame-shaped hemorrhages. But there are two main culprits in diabetes which require our attention and probably require treatment if they are present. First one is neovascularization and second is diabetic macular edema. Let's see in subsequent slides how do these two develop. So if you talk about the pathophysiology, there is a, blood retinal barrier which probably maintains the architecture of the retina and keeps it dry. The outer retinal is formed, outer BRB is formed by the RP, the retinal pigment epithelial cells, and inner BRB is formed by the endothelial cells of the vessels. So whenever they are in normal in functioning and not disrupted, they keep the retina dry. Another important factor is the balance between the hydrostatic pressure and the oncotic pressure. The hydrostatic pressure is basically the pressure exerted by the vessels, and they push the fluid out of the retina towards the choroid. And the oncotic pressure is basically the pressure which is there due to the presence of proteins in the vessels, and if that increases, then that pulls in the fluid from the choroid into the retina. So that if there is a balance between these two, then it keeps the retina dry. So in a non-diabetic patient, this is how a normal neurovascular unit which is present in the retinal layers looks like. This is the RP, this is the internal limiting membrane. The neurovascular unit comprises of Muller cells, microglia, pericytes, endothelium, and ganglion cells. So the function of endothelial cells is basically to form a tight monolayer, and it is joined by junctional complexes. Pericytes basically help in regulating the retinal blood flow, and basement membrane supports the integrity or rigidity, and it helps in filtration barriers. So when we come to a patient of diabetes or a patient with chronic hyperglycemia, it leads to destruction of these cells via various pathways, that is polyol pathway or protein kinase C pathways, and then they release these inflammatory mediators or cytokines or VEGF molecules like VEGF, angiopoietins, TNFs, and interleukins. So whenever these are released, uh, this is how the disruption occurs. This is the normal non-diabetic patient neurovascular unit. This is how they start there will be leakage from the endothelial cells, and there will be release of these inflammatory markers. So whenever there is increased hypoxia or ischemia or the release of these inflammatory markers, it leads to increased expression of VEGF, which goes from non-proliferative to proliferative stage, and further upregulation of VEGF occurs. So then, apart from all the structures that are there in the neurovascular unit, Muller cells are the ones which are probably one of the most important, because they induce factors that forms the tight junction in the retinal vessels. Whenever there is a patient affected with chronic hyperglycemia, these barrier properties affected. It leads to impaired glutamate metabolism, loss of synapses and dendrites, and which further leads to loss of color, contrast sensitivity, abnormalities in ARG and visual field effects. This is a very important picture where a PG and resident probably can understand how the signs appear. This is the retinal pigment epithelium. This is the internal limiting membrane. So all the non-proliferative changes are occurring within these 10 layers of retinal, or probably the outer retinal layers, and few of them are occurring in the inner retinal layers. So this is the dot blot hemorrhage or a hard exudate. They appear like well-defined circular lesions because the arrangement of the cells in the inner and outer nuclear is in such a way. However, a flame-shaped hemorrhage or cotton wool spot appears flattened or a fluffy-like structure because of the arrangement of the nerve fiber layer. Whenever the chronic hyperglycemia persists and these vascular changes of ischemia progresses, it leads to further proliferation of these abnormal vessels, and it grows into the vitreous cavity, where it can be present within the hyaloid and internal limiting membrane, or it can further grow into the vitreous cavity, leading to further changes. So again, we come back to the two culprits which require attention or treatment: the neovascularization and diabetic macular edema. So the neovascularization can further probably proceed, can further complicate the situation by either developing a vitreous hemorrhage, or it can probably put up a traction on the retinal surface, and it can lead to tractional retinal detachment. However, diabetic macular edema itself can lead to vision loss in patients. So coming to some clinical scenarios, this is how a normal fundus would look like in a patient without diabetes, or a patient with diabetes having good control, where there are no signs of diabetic retinopathy. When we come to further changes, these are probably some earliest sign of the diabetic retinopathy is microaneurysm, and the few microaneurysms or dot blot hemorrhages probably we can classify this as mild NPDR. Further, when these hyperglycemia persist, this can further develop into multiple hemorrhages in 2 to 3 quadrants, and it can be labeled as moderate NPDR. Further state of hyperglycemia or ischemia can increase the severity of the diabetic retinopathy, and we can see these venous loops or intraretinal microvascular abnormalities being present, and presence of intraretinal hemorrhages in all the quadrants, which can be labeled as severe non-proliferative diabetic retinopathy. Now, this is a very classical picture of a diabetic retinopathy patient which has reached the stage of proliferative diabetic retinopathy, where we can see signs of non-proliferative, severe non-proliferative as well as proliferative stage. Then there are this venous bleeding and venous loop which is there. Then there can be presence of cotton wool spots, hard exudates, intraretinal hemorrhages. We can see a flat neovascularization present at the disc, as well as a flat neovascularization which is present elsewhere. If that neovascularization occurs within 1 disc diameter of the disc, it can be labeled as NVD. The rest of them can be labeled as neovascularization elsewhere. Now, when this flat neovascularization, if not attended at this stage, laser is not done at this stage, it can probably a normal vessel, or as these are very fragile vessels, it can bleed with itself. If it bleeds within the ILM and hyaloid, it can lead to a subhyaloid hemorrhage. Or if it does, if it bleeds into, if a neovascularization bleeds into the vitreous cavity, it can lead to vitreous hemorrhage. So these are proliferative cases with vitreous or subhyaloid hemorrhages. Probably if the view is obscured, the bleeding has been there since quite time, or there has been profuse bleeding, the view might not be there, and you might require additional investigation in like B scan in order to assess the status of retina, whether this retina is attached or not. So now another aspect of neovascularization is presence of these tractions. So there could be an early traction which is as seen in this uh, and in this picture, where there is a superior temporal arcade, there is a flat NV which is slowly rising into the vitreous cavity, causing some traction. Now, apart from that, it can probably it can probably make the hyaloid taut, and there could be some initial tractions which can be there, which is labeled as thick taut posterior hyaloid, and again, laser would probably to start with and might require VR surgery in a later stage. This is a full-blown tractional retinal detachment. Probably the patient presented late. There was state of chronic hyperglycemia, and this is how a tractional retinal detachment would look like clinically. Whenever, if the patient is still not treated, the surgery is still not done, the distraction can generate breaks in the retinal surface, and it can probably lead to a combined retinal detachment where both regma and tractional component is there. So this was about neovascularization and how it can lead to vitreous hemorrhage or a tractional retinal detachment. Now coming to another important subset of diabetic retinopathy, that is diabetic macular edema. It can be classified into various ways, various based on various classifications. So the age-old classification is CSME, which was given by ATDRS group. Following that, there have been various classifications like OCT based, FFA based on severity, and recent one which we use clinically is the DRCR one. So coming to each of these individually, so CSME was basically categorized based on three parameters. If there was a retinal thickening present at or within 500 microns of the center of macula, that is fovea, then this is the criteria one. If the retinal thickening was there was presence of hard exudates along with presence of retinal thickening, then it is the criteria 2 within the 500 microns of the center of macula. And if there was presence of retinal thickening and any part of which is within 2 disc diameter of the retina center of fovea, that would be again the criteria third, and this was classified as CSME grading. If we have to talk about the OCT based classification that was given by Otani and Kim et al., there are 5 variants in this classification: the spongiform, cystoid, neurosensory retinal detachment. Then, whenever there is a traction on the retinal surface, it can also create cystic spaces. These are posterior hyaloid traction and tractional retinal detachment. In their classification, as given by Otani and Kim, the most common variant was spongiform, followed by cystoid variant. The top 3 variant basically can be treated with anti-VEGF, and the bottom 2 variant would require vitrectomy in order to release the traction and release the macular edema and to treat the macular edema. So currently, the CSME is being labeled as is further modified in clinical settings, and now based on DRCR's classification, if the center involving if it is within 1 micron, if we would label it center involving DME, if it is beyond that, we would label it as non-center involving DME. Another important subset is the fundus fluorescein angiography. There are very limited indications in the current scenarios because we have Octa available. For assessing the macular perfusion. So if we look at this picture, it is divided into three classes, that is focal leak, diffuse leak, and macular ischemia. The focal leaks would be probably because of the few leaky microorganisms that are present, and if this is causing vision loss, we can treat them with focal laser. And in cases of diffuse leak, where there are multiple leaky vessels present, this would probably get treated with grid laser. So another important subset is presence of macular non-perfusion or macular ischemia. This is very important because sometimes when we are treating the patient and on OCT, when we see there is a reduction in the macular edema, but vision is not increasing or patient is not getting benefited because of that. So we have to keep the possibility of macular ischemia or non-perfusion in mind. And this can be either be assessed by doing a fundus fluorescein angiography or recently because of the recent modality of Octa. So FAZ based on ETDRS classification is grade 5 grades based on the size of the FAZ that is there. And based on that only macular ischemia, based on the grading only we have to have this treatment protocol where when up to grade 2 we can treat it as a non-ischemic entity. More than half if it is involved, then probably we can consider steroids in these intravitreal steroids in these patients. And if there is complete damage to the outline, then probably treatment might not benefit and we have to explain the patient GVP. Coming to last subset of this OCT based classifications is whenever we are treating the patient usually tend to ask that what is going to be the prognosis, how will the vision improve. So they now clinically they have some prognostic markers. These are OCT based markers which they have seen in patients with chronic hyperglycemia, which probably has led to poorer visual gain when these patients are treated. So first of all, the first one is presence of cystic spaces in the VMTs. We can see these tall cystic spaces and presence of subretinal fluid. That would probably be a poor prognostic marker. Another important subset is presence of these hyperreflective foci. These are basically lipoproteins that have they are present in the outer retinal layers because of the leakage. And another important subset is the ISOH junction integrity that is disrupted because of the damage to the outer photoreceptors because of the chronic hyperglycemia. Apart from these three, the recent entity which has come in, which has been very well highlighted recently, is presence of this disorganized retinal inner layers, where we can see that the photoreceptors in the outer and inner retinal architecture is completely disrupted. Even if you try and treat this patient and the edema goes down, the patient might not have a good visual outcome or significant functional outcome in this patient. So these are the patients in which we can probably treat with anti-VEGF or intravitreal steroids. But whenever there is presence of traction, be it hyaloid, be it presence of fibrovascular proliferation, which is causing traction, we require vitrectomies in this patient in order to settle out the diabetic macular edema. So summing up my presentation, whenever there is a state of hyperglycemia, it leads to release of these inflammatory markers. Whenever these inflammatory markers are present, it leads to a state of hypoxia or ischemia that can lead to diabetic retinal neovascularization. And whenever there is release disruption in the blood retinal barriers, it will lead to exudation and edema that will cause diabetic macular edema. So management basically revolves around the investigation, that is ophthalmic investigation would include OCT and FFA. And treatment wise, there are multiple options like anti-VEGF, steroids, laser, and vitrectomy, depending on which stage of diabetic retinopathy the patient is presented with. I would like to conclude by saying that apart from complete ophthalmic evaluation, assessment of systemic parameters is a must. We cannot let that go because you might be treating the eye, but there might be systemic parameters that might aggravate the situation. Systemic control is very important. Without that, you might not achieve the desired goal, and follow-up schedule has to be explained clearly to the patient. Thank you.
Thank you, Dipanshu. That was indeed a very good talk. There are so many ways that people can present on this topic, and you have done justice to the topic, definitely, because it's a very difficult topic to explain and put simply. So, my first question will be to Dr. Manoj Khatri. And, sir, like Dipanshu said, the two culprits are neovascularization and diabetic macular edema. Now, when a patient comes to you and you see either one or both of these two culprits, and the patient is an uncontrolled diabetic, would you consider co-managing the diabetes and the ophthalmic condition? Or would you wait for the hyperglycemia and the HbA1c to come down, give it 3 to 4 weeks, and then treat the PDR and DME or both? So that's my question to you. Should we co-manage or give it 3 4 weeks for DM control? Because we saw in his talk about the importance of controlling of diabetes.
Yeah, many thanks, Apurva, for the nice question, and congratulate both Ankur and Dipanshu for wonderful presentations on vein occlusions as well as diabetic retinopathy. So the question here is a couple of things have changed, on the investigative part, as Dipanshu correctly highlighted. What has changed in the management in last 5 to 10 years of diabetic retinopathy and diabetic retinopathy practices is considering these patients as a whole. So systemic evaluation definitely has a major role, but at the same time, post-COVID, a lot of things have changed. So we are seeing more and more patients with advanced diabetic retinopathy rather than seeing them in mild NPDR or moderate NPDR cases. So first of all, definitely the systemic management takes importance, but at the same time, the ophthalmic management also starts concurrently. We don't really wait for the HbA1c, which is, say, about, for example, a 10 HbA1c to become 6 in 3 4 months time. Very rarely it does happen. So definitely ophthalmic management starts concurrently. Only thing which has to be highlighted more and more in the management of diabetic macular edema in Dipanshu's presentation is the presence and absence of tractional versus non-tractional macular edema. Definitely center involving and non-center involving is the way to go forward. But the moment you see tractional macular edema, I think our threshold is more and more towards vitrectomy, early vitrectomy for these patients. And also never miss out on proliferative diabetic retinopathy in any of these patients, as post-COVID, more and more proliferative diabetic retinopathy is on the rise. So I will co-manage it along with an ophthalmic management, just to put it simply.
And Dr. Mukesh Porwal, your thoughts. If the HbA1c is very high, would you give it some time, 3 to 4 weeks, for it to come down, or would you start the management of the eye along with the systemic control?
I would not wait for 3 to 4 weeks, but definitely will involve the diabetologist, because anyway, when we are thinking of giving an anti-VEGF injection, as most of these people would need, the blood sugar levels have to be within reasonable control. Otherwise, there is high risk of infection. So we will not give anti-VEGF injection in an uncontrolled diabetic. So from that point of view, we get the blood sugars controlled as quickly as possible and start the treatment. But we won't wait for 3 to 4 weeks. That would be a bit too much, and it can aggravate by that time probably.
Okay. So my next question is for Dr. Dinesh Garg.
Yes.
What would you say about, say, diabetic retinopathy when it is coexisting, suppose with a pale disc, like a glaucomatous disc, or sometimes patients with NAION come with pale disc and they have PDR changes. And when we do the laser, these patients will lose peripheral vision as well. So, what is your opinion on treatment of florid PDR with pale disc?
See, for PDR and more so in India, I would do a PRP, but as peripheral as possible, probably limited to the beyond the equator. So that the field loss is minimized.
Right.
Otherwise, these patients, get lost to follow up because we don't have much of a proper follow-up system, and most of these patients are paying out of their pocket and they get lost to follow up. And they have so many comorbidities that they get stuck up with one or the other thing. And the eye is then is the last thing on their mind. So I would definitely do a PRP and not resort to monthly injections or advise monthly injections just for this reason that they don't come up on a regular basis, at least in the area which I practice, and I'm sure it is there all over India.
Okay. So, right. Rupak sir, in today's age, with OCT being done for nearly every patient, what are your indications of FFA in diabetic retinopathy or for DME?
Yeah, the role of FFA, Dr. Apurva, is definitely has come down significantly with the OCT because there are a lot of parameters which we decide on the basis of OCT and then treat them. Most important is that this is a non-invasive investigation and you can repeat it off, and there is a quite reliable of repeatability, so that you have the parameters which you can follow it up. So like if the indications are, one is your scenario only, like if you want to do a limited kind of photocoagulation to the area where you can do the targeted photocoagulation. So for like this kind of, when you want to preserve some amount of the peripheral vision, then this is an indication where NION combined together. You can do an FFA and find out what are the ischemic areas. Not that in general you can treat a PRP of just beyond the arcade we treat ablate everywhere. So you can FFA guided targeted laser you can do. So that is one indication. Second one indication, though with majority of them when you suspect for the macular ischemia. And when you are not sure about in the very peripheral neovascularization, and which is not probably possible by the OCT angiography to pick it up. And so these are the, as of now, is most common indication for FFA.
Right.
Though macular ischemia can be picked up very well by the octa, but in presence of significant macular edema, also the octa is little unreliable.
Right. Yes. So my last question is for Dr. Paritosh and Dr. Sir, you want to say something for this question, Paritosh?
Yeah. Basically, one more indication would be recalcitrant diabetic macular edema. That's where I would also do an FFA. And so far as the field loss is concerned, if it's an understanding patient, then and whenever possible, we can offer them a combination of threshold and sub-threshold laser. You see, when for our viewing, most of the time we use our central macula, and most of the other time we are using the post-equatorial superior retina. The inferior retina is used hardly 10% of the time. So if you want to preserve the center and you want to preserve the pericentral superior retina. So in those areas, one could consider subthreshold laser and incremental supplementation depending on how the neovascularization is responding. And at the periphery, you do dense lasering, and in the inferior part, you do dense lasering.
Right. So my last question is for you and for Dr. Deependra. So Dipanshu spoke a lot about PDR and how florid PDR is very well seen as NVD, NVE, even fibrovascular proliferation and everything, fibrous proliferation. Now, my question sometimes is that in nephropathy patients, the retina looks very bald, and actually they would be having PDR, very subtle, silent NVEs in the periphery. So do you have any tips? Because FFA is contraindicated in these patients, at least relatively. So do you and Dr. Deependra have any tips about how to ascertain whether these patients of nephropathy have PDR?
Upendra, you'd like to go in first?
Yeah, sure. I think in general, we have never had a situation where nephrologist has refused angiography.
Yeah, that is there.
So yeah, but to answer your question, suppose there is a relative contraindication. I think you can still go ahead with Octa and see if there is ischemia. Because if there is significant ischemia and a suspected neovascularization, I will go ahead with PRP rather than seeing a frank neovascularization for these kind of patients, because compliance also is going to be an issue with these patients. But interestingly, most of these patients, their retinopathy starts regressing by the time nephropathy sets in. So we are not in that aggressive mode. Just like when we see young patients with aggressive florid PDR who have healthy kidneys. So it is never a clinical challenge, but I think because this session is for fellows, one thing I would like to add to all the good comments made by all panelists already, that we all should, when we are learning to treat diabetic retinopathy, we should try to correlate the severity of retinopathy with vision. And wherever it is not correlating, we need to do more and more imaging and investigations. There can be an undetected traction. Sometimes they have optic nerve head issues like AIUN, which has happened few months back. And of course, macular ischemia, everybody highlighted. So I think this is something which everybody, I think, should be looking at when we are seeing retinopathy. And one more reason for doing FFA still, despite having Octa and OCT in our practices, when you see vitreous hemorrhage in one eye and fellow eye has very minimal retinopathy. So I think there you want to differentiate whether it is PVD-induced vitreous hemorrhage or do we really have PDR in both eyes. Sometimes FFA can surprise us actually.
Yes.
It looks like mild, moderate NPDR and it turns out to be PDR on FFA. So that's it. Thank you.
Last comment by.
So on the last point, if there is significantly unequaled retinopathy, please do a carotid Doppler. We might be dealing with unilateral ocular ischemia. Now, with regards to the nephropathy comments, as he very rightly said, often with progression of nephropathy, because a lot of proteins get thrown out by the diseased kidney, a lot of these pro-inflammatory cytokines also get thrown out in some people. And in those, the retinopathy might actually regress, but the ischemia keeps progressing. Now, herein comes the role of it's very, very important to do a good clinical examination. So do not restrict yourself to just an indirect ophthalmoscopy with the 20D. Please use the 14 or 15D lens also within the binocular indirect ophthalmoscope. And please, you do a slit lamp biomicroscopy. So if you see featureless retina, it's a sign of ischemic retina in diabetics. The second thing is that with these modalities itself, you would pick up what is called rete mirabile. That is very flat neovascularization. Okay. So this is very important to pick up, and these eyes, they need to be ablated quite significantly, because otherwise it can, they tend to progress and lead to blindness, So you need to look at these eyes. May I just quickly comment on neovascular glaucoma also, please?
Yes, please.
So whenever you find neovascular glaucoma at an early stage, the treatment would be anti-VEGF and aggressive PRP and trabeculectomy. If recurrence or late stage ones, then anti-VEGF and the valve procedures need to be done. Another comment was about if you find that there is resistance to recalcitrant macular edema, look very carefully on the OCT for presence of a thickened posterior hyaloid face. these eyes often tend to have what is called a vitreoschisis instead of a clean, clear-cut PVD, and the posterior hyaloid might actually be thickened and causing resistance to your anti-VEGF treatment. Thank you very much. And it was a very nice presentation. Thank you.
Sure.
Thank you, sir.
And just one thing I wanted to add, like sometimes even these kidney patients and all, beyond a clinical examination, a wide field fundus photography might pick up a few more things compared to what you have seen on a clinical examination. Sometimes the patient is not that cooperative or something. So even if we are not able to do angiogram, a wide field photography might help.
Yes.
And whenever we do angiogram, we use a half dose of the dye in these patients.
Yes.
Since we are talking primarily to the postgraduates and fellows, let me just clarify one thing, that a wide field or ultra wide field photography is superior to examination only in extremely uncooperative patients where there's just no possibility of seeing the fundus. And this would probably occur in less than 1% of cases. 99% of the cases, a good clinical examination itself gives you enough of light, and then your photography, whichever way you do it, is more for documentation.
Yes,
definitely.
The second thing about nephrologists, more than a contraindication to FFA, FFA is not contraindicated if a patient is on dialysis, so there's no problem. But in others, more than FFA, nowadays the nephrologists are crying hoarse about use of anti-VEGFs. One needs to be very careful in how frequently we inject them, and always keep the physician with you.
Yes. Dr. Dipen, last comment.
I think I fully agree with Dr. Paritosh that I think when fellows and our anterior colleagues are learning to diagnose diabetic retinopathy, the most important thing to learn on indirect ophthalmoscopy is to learn to identify traction, because that is something which get missed, especially by the beginners. And there you can take the benefit of OCTs. If you have any area of suspicion, take that patient back to OCT and see. OCT will nicely see you show you the traction, and then again you can look at that patient with indirect. So I think it's always a correlation of clinical examination and imaging, which improves your clinical exam techniques also. Right?
True.
Definitely.
Yes. Thank you so much. Again, a very illuminating discussion by all the expert panelists. Our last talk is by Dr. Soumya H.V. She is, for the people who don't know, she is a very, very popular teacher in Karnataka Ophthalmic Society, one of the best teachers in our state. She's a professor of ophthalmology at the JSS Academy of Higher Education and Research at Mysore. And she's done her fellow medical education from St. John's, Bangalore, fellowship medical retina from Retina Institute of Karnataka, FICO in 2010. And like I said before, she's a passionate teacher and she makes the toughest topics very simple. So I'm eager to listen to her. Her topic today is intravitreal injections, drugs, dosage and delivery. Over to you, ma'am. Please share your screen.
Is my screen visible?
Yes, ma'am.
Yes.
Yeah. Thank you, Dr. Apurva, for that kind introduction. And one of the teachers, Karnataka. Anyway, thank you so much. Thank you so much for the kind introduction. And at the outset, my heartfelt gratitude to the program directors, Dr. Santosh Honavar sir, Dr. Mathur sir, the moderator of this session, and the expert panel. And I thank them for having given me this opportunity to speak on one of the most important topics of intravitreal injections, the drugs used, the dosage, and the delivery. So the first intravitreal injection was described in 1911 by Dushman and Home. They used an air bubble to tamponade retinal detachment. Now, Von Salmon and Payman et al. Heralded the use of intravitreal antibiotics for bacterial endophthalmitis. Now, indeed, this is one of the most commonly performed ophthalmic procedures and has become a standard of care in ophthalmic practice. Now, why intravitreal? Why do we have to choose this route? Because it's a logical method for physicians to overcome the blood-retinal barrier. Now, it also ensures that the therapeutic levels of the agent is achieved at the target tissues immediately and a highly targeted drug therapy. So therefore, it circumvents the systemic absorption and therefore result in toxicity of the agent to a greater extent. The pharmacokinetics of these drugs have been complex and incompletely understood. The injected substances, they tend to move throughout the vitreous body. Either it could be by bulk flow in fond vitreous or by diffusion in the liquid vitreous. Now, the factors that affect the clearance of these substances include there could be some alterations in the normal anatomy and physiology of the eye, and also depends upon the size of the compound injected. Now, my plan of my presentation would be the classifying the intravitreal agents, the indications for each type of intravitreal agent, the pre-procedure assessment, which is one of the most important assessments one has to do, and the procedure in detail, the complications, the contraindications, and a note on individual drugs. The intravitreal drugs could be classified as one of the major or most commonly used, that is anti-VEGFs, starting from the pegaptanib sodium, bevacizumab, ranibizumab, aflibercept, and faricimab, and the intravitreal steroids in the form of triamcinolone acetate. The antimicrobials which are commonly used, that is vancomycin, cefazolin, ceftazidime, and amikacin. The steroid implants in the form of dexamethasone and fluocinolone. The antifungals which are used intravitreally or amphotericin B, fluconazole and voriconazole. Ganciclovir, foscarnet, and cidofovir are the antivirals which are used in cases of viral retinitis in AIDS patients, people on immunosuppressants, and also in patients with malignancy who have fulminant viral retinitis. The air and the expansile gases which are used include sulfur hexafluoride, perfluoropropane, and hexafluoroethane. Antimetabolites which are used are melphalan, topotecan, and methotrexate. The indications, according to the group of drugs that we discussed, for the anti-VEGF would be the primarily neovascular AMD, vein occlusions, proliferative diabetic retinopathy, diabetic macular edema, preoperative in surgery for PDR and vitreous hemorrhage, in idiopathic polypoidal choroidal vasculopathy, and ROP. The need and the choice of anti-VEGF agent is customized according to the individual patient and the retinal condition. The indications for antimicrobials include bacterial endophthalmitis, for antifungals include fungal endophthalmitis, and retinoblastoma in case of antimetabolites. Coming to the pre-procedure assessment, very important, if we could classify it as a systemic and ocular point of view. The systemic examination is definitely we go in for a physician fitness, especially with reference to the uncontrolled blood pressure, uncontrolled diabetes, and also ECG changes. Because many often when we are giving anti-VEGF agents, we also need to look about the condition or history of any CVA or MI in the previous 6 months or 3 months, because where it is definitely we don't go in, or probably even many a times our physicians also have, in fact, they search for the literature because probably many a times we give them physician fitness for all the anti-VEGF injections. So hence they're also more probably I can say they are also very cautious in giving the physician fitness for these injections. So an eye on systemic status of the patient, uncontrolled blood pressure, uncontrolled sugars, and cardiac status evaluation is very important while even before we proceed with injections. And as far as ocular condition, any infection, especially in the ocular adnexa, including meibomian gland disease, blepharitis, and active infections like hardyolum internum, externum, chronic blepharitis, and meibomanitis is absolute no-no. At least we have to treat and then give intravitreal injections. Then to look for a patent nasolacrimal duct and a negative regurgitation test. Pre-injection IOP checking is also important because many a times we need to give injections for people who are already on anti-glaucoma medication. So I think it becomes probably an ophthalmologist would be very comfortable doing all these tests even before giving an intravitreal injections. Now, routine use of topical antibiotics is again a debatable topic because many a times some of them do give, some of them do not give, but I think majority of them would agree in giving topical antibiotics the day before the injection. Now, coming to the procedure proper, an informed consent has to be taken, which should include the off-label use of the drug, if any, and occurrence of thromboembolic events, then risk of cataract formation and glaucoma, particularly when we are using intravitreal steroids. And we do have the informed consent in ophthalmic surgeries by AIOS, probably even describing the different types of intravitreal agents which are there. So definitely, we in our hospital definitely follow the AIOS consent form for type of intravitreal agent that is to be given. Now, procedure as for any intraocular surgery and as stringent as for any intraocular surgery, we prefer to do the injections in the operation theaters. Then coming to the different types of anti-VEGF agents, yes, some of them have to be stored between 2 to 8 degrees centigrade. We also look for their expiration date, batch number, any tampering, and any unusual content it is there. 2 syringes should be sent on day 1 for microbiological culture. Batch is released if there is no growth on culture after 48 hours. Now, if using Avastin, we used clean the rubber stopper with betadine, and then it has to be done in an OT and scrubbing and donning the glove with standard hand washing principles. Very vital to monitor the patient's vitals like pulse, blood pressure, and even ECG recording. Surgical timeout to verify the patient's name, the intravitreal agent that is to be given, and laterality. Painting and draping mandatory. Drape using a sterile linen and an eye drape. Now, all of us use 10% povidone iodine for skin and 5% povidone iodine for the cul-de-sac. And we practice 3 times painting and then waiting for considerable time. In order, probably we spend around 10 to 15 minutes even before we give intravitreal injection. Now, as taught by my teachers, it's like a betadine bath. So that because we know that the intravitreal injection and ophthalmitis also has a little higher rate. So it's better that we be safe on giving more of betadine for the conjunctival cul-de-sac as well as for the skin. And then topical proparacaine drops is used. It's better to use topical drops instead of the gel because sometimes the gel may hinder or it may come in the way of the betadine acting on the ocular surface. So topical proparacaine drops would be better preferred. Use of eye drapes, and to keep all the necessary things ready. The equipment or the instruments that we would require would be a large bore needle to draw the agent and a 30 gauge needle and a 1 cc syringe. Then we use of betadine with the swabs and then use of a sterile eye drape. And then topical antibiotic drops after the procedure. And again, this is again a debatable question, pre as well as post, and even during intra. But then we do use a drop of topical antibiotic even before probably putting a bandage. Then sterile cotton buds, sterile globes, drapes, eyelid speculum, and caliper or other measuring device to exactly locate the site of intravitreal injection. The usage of sterile speculum is mandatory and very important to know that to minimize or even not to even talk during the entire procedure, because from some studies in the literature have shown that the occurrence of endophthalmitis in intravitreal injections, sometimes the contaminants can be from the surgeon's mouth or the patient's mouth or the oropharyngeal droplets. So it's always either wear a mask for the patient as well as surgeon. Anyways, we would wear it. But to minimize the talk in the entire procedure is always better. The 5%, as told earlier, 5% povidone iodine drops in the sac for a contact period of 3 minutes, and we repeat it for 3 or 4 times. The most important step in prevention of endophthalmitis and installation of topical anesthesia before the povidone iodine, and it has to be the last agent applied to the intended injection site. Again, depending upon where do we give the intravitreal injections, generally adults or 7-year onwards, 4 millimeter in phakic individuals, 3 millimeter aphakic, 3.5 to 4. So probably for convenience sake, 3.5 millimeters from the limbus could be taken while giving the intravitreal injections. Now, needle selection, 27 gauge needles are used for crystalline substances like triamcinolone. 30 gauge would be used for anti-VEGF agents. The needle length anywhere between 12.7 to 15.75 millimeters is recommended, and a large bore needle is used to withdraw the drug from the vial. Now, sterile calipers to mark 3 to 4 mm depending on whether it is phakic or pseudo-phakic, and we use them to mark the site of the intravitreal injection. And then any quadrant would be chosen, but preferably it is an infratemporal quadrant that is chosen for the ease of access, and we need not have to go over the nose and give it. And then with the help of the 30 gauge needle, the surgeon directs the direction of the syringe to be the mid-vitreous cavity. And then it has to be not a sudden influx of the agent, because it would cause a reflux, and then because of the so many vitreoretinal adhesions there. So it's probably a stable and a controlled entry of the drug into the mid-vitreous cavity. And care should be taken that as soon as the intravitreal agent is given, a sterile cotton pledget is to be placed in order to avoid reflux. Then how do we check? We always check with the, for the light perception, and then for the presence of hand movements to note the central retinal artery perfusion. And again, post-injection antibiotic is used, and then paracentesis, generally it is not recommended. Probably if we are giving intravitreal drug in a patient with glaucoma, or if we're expecting that there is no central retinal artery perfusion, or a patient is not able to perceive whatever you have asked for the light perception or hand movements, a use of paracentesis is definitely indicated. The injection technique variations, again, we have a step-like entry or a straight injection path. A step-like entry is, again, minimizes the chances of infection, minimizes chances of reflux, but most of all the surgeons would prefer a straight injection path. Now, post-operatively, what all do we monitor? We monitor the post-injection IOP, examination of anterior segment. Again, very important to note here, many of them would have betadine toxicity. So probably even irrigation of the leftover betadine povidone is a good idea. And many of them do develop punctate lesions on the cornea because of the betadine toxicity. So anterior segment examination for presence of any anterochamber reaction, and then indirect ophthalmoscopy, and very important to know, explain the patient about the warning signs and symptoms, and to share the contact information, to be examined on post-injection day 1 and 3. And use of post-injection antibiotics is again left to the discretion of the treating physician. And IOP also can be monitored in the office. Now, coming to the individual group of drugs, just a note on VEGF. Vascular endothelial growth factor, also known as earlier as vascular perfusion factor. Again, most well appreciated growth factor in ophthalmology. It is 50,000 times more potent than histamine in causing permeability. There are different isoforms of VEGF, but human isoforms are 121, 145, 165, 189, and 206. Now, what happens to the vessels that have been acted upon by VEGF? It causes endothelial cell hyperplasia. There is increase in the permeability, there is loss of pericytes, increase in the tortuosity, and this would predispose to hemorrhage and leakage. Now, what are the principles of anti-VEGF is? This blocks the VEGF, in simple words, it blocks the VEGF molecule, decreases the abnormal new vessel formation, thereby decreases the leakage and swelling of the retina, and stabilization and improvement in vision. Different classes of anti-VEGF drugs that are available. So depending on what are the active molecules. So bevacizumab is a humanized monoclonal antibody. Ranibizumab is a fragment. Aflibercept is recombinant protein which attaches to both VEGF receptor 1 and 2. And brolucizumab is a humanized single-chain variable fragment. And faricimab is a bispecific antibody. Hence, you have a multimodal approach for faricimab. The different dosages. So we all know that around 0.05 ml is generally given, not more than 0.1 ml. Sometimes when a larger volume of intravitreal, especially when we are giving it for intravitreal antibiotics, you might have to give a little larger, but generally 0.05 to 0.1 ml is what generally anybody would inject. So bevacizumab is 1.25 mg, ranibizumab is 0.5 mg, aflibercept is 2 mg, brolucizumab and faricimab is 6 mg. The bevacizumab would just a non-specific blockade, whereas ranibizumab binds VEGF-A and B. Aflibercept also has an action on the placental growth factors. Now, faricimab targets both VEGF-A and angiopoietin 2. These are the different, again, molecules and their molecular structure. Now, this is how the FDA approval or the journey of anti-VEGF injections started. These, again, the different characteristics of all the types of aflibercept, conbercept, their vitreous half-life, and what are their modes of action. There are different studies that have been done on anti-VEGF day, especially in DR. We all know the BOLT, which should prove that bevacizumab is more than laser in mean gain in visual acuity. And Rise and Ride not only told about the monthly and bi-monthly fixed dosing regimen, and also discussed in detail about the PRN and the treat and extend protocols. Similarly, for aflibercept, we had Vivid and Vista, which that was little superior when compared to laser mean gain visual acuity. Kestrel and Kite had studies on brolucizumab and Yosemite and Ryan on faricimab. The contraindications for anti-VEGF, like all of us have now discussed, fibrovascular proliferation threatening the macula, active or surrounding ocular inflammation, known hypersensitivity to anti-VEGF agents, uncontrolled hypertension, cardiovascular disease, and major systemic events in the past 3 months. Coming just a few information on biosimilars. We all know biosimilars are a biologic medical product which is almost identical to that of the original product. Now, why do we have biosimilars? Because at a less overall cost efficient as well as developed in a lesser time. And one important thing is it is more prone to heterogeneity and immunogenicity. There are different there is a need for biosimilars because it may be cost of anti-VEGF may be a deterrent, and increasing the cost negatively impact the patient compliance, hence can be used to reduce the treatment cost by 25 to 50%. So there are many biosimilars for all, including ranibizumab, aflibercept, and bevacizumab. I'm just not going into the details of these biosimilars. Then concerns are, again, reports of intraocular inflammation with all these innovator molecules. Immunogenicity remains a concern and more prone to heterogeneity, hence impurities and overall stability and legislation concern. The complications of intravitreal injections, again, increase in IOP. There may be a transient increase in IOP just after the injection, but then again it settles down within no time. Subconjunctival hemorrhage in 10% of cases. Reports of intraocular inflammation, especially with brolucizumab, and development of cataract and glaucoma with steroids, and endophthalmitis, again, a post-injection endophthalmitis, risk of non-fatal stroke